Hello. I am terribly sorry about our surprisingly long hiatus from putting up anything on the YouTube channel. I've just had a really busy couple of weeks in terms of teaching, grading, and other research activities. But the exciting news is that we have tons of research and that really does need, getting out there quickly. So you will be listening to a lot of exciting stuff that we've been doing in our team out here in IIT Hyderabad in psychosocial healthcare. But for today, we're going to be talking about a survey that was done a couple of years ago with a super multidisciplinary team that comprised Indra Jali, who is also the PI of the study and is an expert in cultural studies. Amrita and myself are psychologists, and Dr. Badrinarayan Rath, who is the HOD of the Department of Liberal Arts, is also an economist. And we also had Dr. Soumya Jana, who is an electrical engineer. So you can see how multidisciplinary our team really is. So the idea of bringing a team like this was we wanted to do like a front runner pilot study that gave our engineers at least a basic idea about the mentality, the spending behavior, the attitudes that a particular set of people from a rural place would have towards innovative healthcare technology. So in our study, as you can imagine, it was super explorative, and we just wanted to get a sense of how people responded to, to any kind of innovative technology. So without much ado, I'm going to start, talking to you guys about the study and also what we found. So in terms of the site selection, we wanted a place that was fairly close to IIT Hyderabad so that we could, go up and down a bit more easily. So we surveyed a bunch of villages within about a 70-kilometer radius from IIT Hyderabad. And we zeroed in on Tangidapalli, which is about 30 kilometers from IIT Hyderabad when it was placed in the temporary campus in ODF. In Yadumailaram, basically. And what surprised us about Tangirpalli was that we couldn't find it on the map. We did want a place that was not reachable through Google Maps in that sense. So Tangirpalli was fairly ideal because it would represent a locality or a rural space which was difficult to detect, basically. And the nearest town to Tangirpalli was Shankarpalli, which was about 20 kilometers away. And Shankarpalli is a fairly, well-supported town, I would have said. It has a couple of healthcare clinics. It's got a bus stop. It's got the works. And the total population in Tangirpalli was also fairly ideal, just under 3,000, with a fair representation of males and females. And the number of households were about just under 500, which is also what we had wanted. We wanted a small size kind of manageable village. And the main occupation was agriculture and day wage labor. So that also represented a wide number of villages within that Telangana region. So we thought that Tangirpalli was perhaps the perfect location for us in terms of representing or representation of villages in that in Telangana, especially within about a 50-60 kilometer radius from the city of Hyderabad. And what struck us the most, and this is perhaps what made it more interesting for us, was that there was no local doctor. They did have a PHC, but they had this nurse who was very occasionally visiting them. So they didn't have readily available formal care. And that to us was a very important thing, because the whole idea of that program, the cyber physical systems, was also to reach those who were not reachable and to those who were not able to access formal care in an efficient or a quick manner. So in terms of the methods of our research, we had decided to go with purposive sampling of about 500 participants, and we use a range of scales. The Rotterdam Symptom Checklist is a standardized, symptom reporting scale. And basically the participant has to rate that symptom on a 4-point Likert scale, and to say whether he experiences this frequently or not at all. And in terms of trying to measure health awareness and risk prevention, because I'm a health psychologist, and I'm a very strong advocate for health literacy, and that and I very strongly support the fact that there are so many people out there who are even unaware that health literacy plays a very big role, or health awareness, or awareness about efforts of risk prevention play a big role in long-term well-being. So we added a 11-item self-report measure that was particularly designed for this study, that asked a range of questions, right from what kind of medical treatment that they had received, because that would be an opportunity for them to learn more about health and illnesses, to looking at how they would rate the government's attitudes towards risk prevention. And in terms of medical costs, we designed 5 questions that were aimed at looking at people's willingness to spend and basically spending behavior. In terms of the willingness to take up healthcare activities, because this was also, bear in mind, a study that we were looking at how willing or how motivated participants would be to actively engage in their health and well-being, right? So we came up with 5 hypothetical questions that were used to assess how willing people would be to participate in health monitoring behaviors. And then we obviously had a bunch of questions on attitudes towards technological advances in health. So we asked a whole bunch of questions over here. We asked patients about how would they have even wanted a device to be like? Where would they would it be okay about using this device, on which part of their body, basically? Things like that. So we went and asked a whole bunch of questions that had something to do with point of care services. And finally, we used another standardized questionnaire that looked at health locus of control. Now, health locus of control is a concept that very briefly to put it very briefly for you, is to say that people will either have an internal or external locus of control, which is to mean that people will either think that they will be able to affect change, healthcare, or well-being based change within themselves, or they believe that a lot of this happens due to external circumstances, which could be environment, fate, God, whatever. So we wanted to measure this, just because there is some research to support that people with internal locuses of control loci of control tend to be more active in their healthcare engagement in general. So again, in terms of how we collected the data, we had project associates. We had 3 project associates who went door to door, talking to every individual who was above the age of 18. And they told them about the study. They asked if they were willing to be participating in the study, and if they were, they took verbal or written consent, and then went on to asking the questions. Now, in terms of how they asked the questions, because a large proportion of the population was uneducated or illiterate, to maintain homogeneity, the project associates would read out the questions as they were, and the participants responded with whatever rating they thought was appropriate. And in terms of ethics approval, at that time, IIT Hyderabad did not have an ethics committee. So we went on to getting in touch with the village panchayat head of our district, and explained the study to them, and they had given us ethics approval to to do the study in their village. In terms of the demographic information now, we interviewed, as I previously said, 500 participants, of whom 300 were male and 200 were female. And it was interesting to note that more male participants were formally educated as opposed to their female counterparts. And the average household income was about 3,000, which is fairly good given our national level statistics on this. In terms of the main findings, I'm only going to be talking about the findings that talk about symptom reporting and attitude towards healthcare in this talk. So about 29% of our participants had a diagnosed illness. So that's a fair number of participants who had actually sought healthcare services and sought a diagnosis. So their help-seeking behaviors perhaps are fairly good, but also it's alarming to see that there are 30%, nearly 30% of the part of the village that was experiencing some form of a diagnosed illness. But what was more worrying was the fact that participants who were lesser than 50 years of age reported a lot more illness-related symptoms, particularly weight loss, lack of energy and appetite, backaches, and tiredness, which is suggesting that they must be engaging in a lot more physical activity and a lot more physical burden, which kind of relates to why they would have been more in number in terms of reporting these kind of symptoms. And when we asked about spending behavior, it was very interesting to note that when the participant had to consult a doctor, it would cost them between 100 to 200 rupees per visit, and that included the commuting, the consultation fee, and the medicines. So that's a lot of money, when a single household is earning 3,000 rupees, and to spend 200 rupees on healthcare is tremendous, basically. And what is even more disheartening is that about 70% of the participants would have had to travel at least 10 kilometers to consult a qualified doctor, in spite of having a PHC in their village. Now, 10 kilometers may not seem like a lot, but bear in mind that they would have to rely also on the public transport. And we don't know when the bus will arrive. We don't know how long the bus will go, on to the point of where they needed to get down. And so there's so much that they are dependent upon. There are so many ifs and buts in that journey. So 10 kilometers may be just a number to us, but it's an entire day to the participant. Now, in terms of the factors that determined willingness for the participants to participate or actively engage in health preventive behaviors was things like medical checkup costs, the distance that they would have had to travel, the opportunity cost, the health locus of control. So if they had an internal locus of control, they were more willing to participate in health risk preventive behaviors. Age composition, and the gender played a role in terms of their willingness to take up health preventive behaviors. And participants felt some ownership towards their health and illness. They did report relatively high scores in terms of internal locus of control. And what was very heartening to note was that more than 96% of the participants said that they were willing to spend that kind of money. They were willing to spend $100 on using a technological device if it helped in detecting any kind of illness early on or helped in terms of prevention. Now, what was even more encouraging was nearly 100% of them were willing to go for a checkup which was which is very heartening to note, because there's a lot of research in India that shows that early risk prevention and early detection is still very problematic at the rural healthcare level. But here we had a group that were saying yes, we would want to go and get these biannual checkups, even if it meant that I would lose out on my day wage. But when we asked about the type of equipment that they would have preferred, we found that the most interesting finding rather was that 88% of the women said that they wanted the device to be the size of their palm, and that they only wanted it to be used for 10 minutes. And most of the men had no preferences about this. So that was really striking to us, that the women had preferences about what size it should be, and for how long they would allow for a technological device to detect any kind of illnesses or give them up a checkup. So that's very interesting to know that there's some kind of a gender disparity or difference over there. So in terms of the discussion, first things that struck us was that there were younger participants who were reporting more symptoms. Now that is actually corroborating with the growing global concern about how younger, more productive populations are reporting more health-related issues. Now, when we look at the symptoms, you'd see that a lot of them were associated with physical aches. And this corroborates again with research that looks at alcohol and alcohol abuse, and says that a lot of the people from rural setups tend to have local alcohol such as toddy or kallu to help alleviate these kind of physical aches and pains. So it is troublesome, nevertheless, to see that there are this vast number of young, able population that is reporting physical issues. Now, the other thing that was striking was that the cost of seeking healthcare was pretty high. 200 rupees a day, 100 to 200 rupees a day is fairly high for a household that's only earning 3,000 rupees. And it really emphasizes the need for developing point of care solutions, so that it removes the hindrance or the burden of patients having to, or participants or villagers, individuals, whatever you want to call it, having to travel a long distance just to seek a basic diagnosis. And what was striking also when we went and did the field visit was that the school was the most opportune location to provide these kind of health services, because that's where the educated teachers are who could be trained alongside the ASHA helpers. And it was also the place where we could target very young minds and sensitize them to the need for engaging in healthy lifestyle choices at a very early age. And when developing technological devices, it's very important to be sensitive to women's needs. Now, this is something that I, as a researcher, also come across frequently enough, because I also work with a scientist and engineering team, that technologies are great, but one needs to bear in mind what are the women's needs in this. It's it is important to understand the target population's needs, of course, but especially to take into account what are the women's requirements of this, especially in a kind of cultural environment like India, where women have a certain role, expectation, status, and it's important to kind of take that into account. Something that I did not report in this presentation was that a lot of the women also said that they would want the device to be used only in spaces on their body that was visible. So those were basically their arms. That's it. So, we need to kind of be sensitive to these kind of nuances that are, relatively culturally driven, I would say, but also very strongly socially embedded. And I always wondered about this. My team also did. We all were wondering, they're so positive. They're so willing to say yes, we will spend this kind of money, and yes, we would welcome technological devices. Such a thumping positive response was something that we needed to take with a pinch of salt and wonder whether there was some level of social desirability going on over here. Were they responding positively to us simply because they wanted us to deploy those kind of technologies in their village? So, quote unquote, kind of adopt that village. So they were giving us responses that were desirable to us, really. So these are the overall findings of our study, and it was it was a really exciting journey for us to work as a team together, but also to find out such interesting details about a very remote villages, residents' opinions and attitudes and behaviors towards health. Well, that's the end of our presentation, and thank you for listening. If you have any queries or questions, comments, please feel free to drop an email to me at mahati@iith.ac.in. And if you have any further questions, you can also get in touch with the study's PI, Indira Jalli, or the co-investigators, Dr. Amrita Deb and Dr. Badrinaran Rath. Or if you want to explore or find out more about the technological arm of the study, please get in touch with Dr. Soumya Jana, who is an electrical engineer. Bye.